Today I'm going to talk to you about diabetes on a budget for people with type 2 diabetes. This presentation was a challenge, let me tell you, because I don't know how tight your budget is. I'm not sure if you have Medicare. I'm not sure if you have a supplemental. And some of you, unfortunately, may be homeless and living with type 2 diabetes, which is a pretty tough situation. So I'm going to give you the best I can tell you about the medications, the generic ones, the least expensive ones, as well as the devices. Now, just many of you know that TCOID used to put on face-to-face conferences up until the pandemic. Remember that little tiny thing called COVID-19, that virus? And now we do virtual conferences. So I want you to pay attention on our website, not only for upcoming conferences for people with type 1 and type 2, but also our video vault where you can learn on your own at any time, free of charge. And I'll be referring to the video vault quite a bit during this presentation. And just to let you know, thanks to a fantastic group of folks that work at TCOID, we now have reached over 20 million people worldwide, 100 countries, and that's the silver lining for our organization, because we now can reach more people and they can enjoy our education content anytime, free of charge. This is just a slide that we are very proud of, showing the number of people we touch per month from before the pandemic up till now. And you can see now we're reaching 2.5 million folks a month, and over 100,000 folks go to our website every month. So if you're not visiting our website and picking up lots of good information, entertaining videos, then you should put that on your list of things to do. Okay. I love this statement because it's so true. Diabetes is not a rare disease, and it is not an inexpensive disease. The medications and devices for type 2, if you don't have insurance, are unreachable, super expensive. Even the copays for some of the insurance programs that some of you have are super high. You have that donut hole. Gosh, I love donuts, but not that type of donut, where you have to put out a ton of money before you start receiving benefits. So once again, I'm going to be talking about how you can get more resources in a second and at the end of the presentation. So the purpose of this presentation is really for those of you with type 2 who do not have access to the latest and greatest and most expensive oral agents and injectable medications, as well as devices. So I'm going to show you how to economically take control of your diabetes. This is a snapshot of the section on our TCOYD website that's relatively new, has access information, tons of access, how to get medications at a reduced cost, free of charge. And there's many sources, believe it or not. Many folks like yourself do not know about them and do not utilize these resources. You don't take advantage of them. So we put a lot of time and effort into this section of our website. And you can see it's tcoid.org/access. Now, this is an important statement. Get type 2 diabetes, control it, and live longer because of it. And that's a very important statement. Type 2 diabetes is not a death sentence, but we do know that if you get type 2, you manage the glucose, you manage the blood pressure, the cholesterol, that's all associated if you have type 2, and you will live longer and healthier. And sometimes, and many times, longer than your counterparts, the same age, the same sex, the same weight, that do not have type 2 diabetes. So that's an important point. So what are the unmet needs in all of you folks with type 2? And I feel like I could be an honorary type 2 because I've been treating patients with type 2 diabetes my entire career at the Veteran Affairs Medical Center, at the University of California, San Diego, and all the folks with type 2 that we've met through the years of running TCOID. Weight. We know that preventing and controlling weight is a huge issue. And I put it on top because a lot of folks with type 2 put that as their most pressing issue. There's a high rate of heart disease, and we're going to talk briefly about the general concepts of reducing heart disease. This is not the lecture to go into that in detail, but we do have excellent presentations. I don't want to say lectures because they're not really boring lectures. They're more like entertaining lectures, edutainment on our website, but it's important. And it's tough to make lifestyle changes, especially when you get type 2 later in life. Someone's going to say, hey, you're not going to get on spandex and go to the local healthcare club and exercise 5 days a week, or you're not going to start running marathons either. It's small baby steps. I have a few slides on that at the end. Adherence to all the medications that folks with type 2 have to take is a challenge. Medications for your glucose, your blood pressure, your cholesterol. And then, unfortunately, folks with type 2 are not exempt from other problems like arthritis and things like that. And there are emotional issues living with type 2. It's tough. Dealing with your family members, with society, with your caregivers, and there's a higher rate of depression. So we also have presentations by our famous touchy-feely guy, Bill Polonsky, on our website. Now, I'm not going to get into this slide in detail, but the purpose of this slide is to tell you there's a lot more to managing your type 2 than just glucose levels. And I think two of the most important are blood pressure and cholesterol levels. There are goals and there are medications and non-pharmacologic approaches to reach those goals. And that's very important. You can't forget about the B and the C in the A, B, C, D. A is just aspirin and, of course, your glucose control. And lastly, the D is about diabetes medications. So we're going to get into that in a lot more detail. Now, I thought you'd like this slide. This is a very old slide from the 1970s, but this is how we treated people up until the 1980s. I love this. It shows diet, exercise, and medication. And just to point out that, look at the size of this needle for those of the folks that went on insulin back then. Look at the food that they're recommending. A big slab of roast beef with a slab of fat around the outside, whole milk, canned green beans, probably from Costco, white bread, and that was this was supposed to be a model diet. And believe it or not, back in the 70s and 80s, there was only one pill to treat type 2 diabetes. The other thing I think is pretty funny about this slide, and I always point out that this guy's walking his dog, he's all hunched over. Why don't you loosen up on the leash a little bit so you don't have to bend over so much? I don't get it. But anyway, that was my education when I got diabetes in 1970. And back then, all type 1s and type 2s were put together in the same education class. That's why we have our separate tracks and our separate areas in the video vault. Okay, so now I'm going to cover the many different ways you can control your diabetes on a budget. But I'm not going to get into the more expensive, newer drugs in detail because that's not what this lecture is about. But once again, if you're on Medicare, you may be eligible to get some of these newer medications through your plan. So I'm going to refer you to the video box a few more times. Let's talk about the diabetes toolbox. And I can tell you, since I've been in diabetes, the toolbox has grown tremendously. Let's look at the different oral medications, or I should say all the medications, injectable as well, that have become available since insulin in the early 1920s. You can see that it goes on the left, and look at the spaces in time from 1920s up to 1950, which was the sulfonylureas. And in fact, I'm just going to show you right away, of all these medications, these four are generic and very inexpensive. They're very effective if used correctly. And I'm going to go through these in detail. And you can see how what an increase in number of options we've had, going all the way up to the GLP-1 receptor agonists, the SGLT2 inhibitors, and other medications, some of which we don't really use on a great level. Okay, these are the generic medications. We have insulin. Not all insulins on the market are generic. And I want to point out, just to educate you, you can see that part where it says biosimilar equals generic. It's true. When we talk about insulins that are made more inexpensively. We call them biosimilars. And when we talk about oral medications like, oh, I don't know, pioglitazone, for example, Actos or sulfonylureas, we call them generic. So just to give you that little education. So sulfonylureas, they've been around for a long time, since the 1950s. There's like probably 20 or 30 different ones. These are the ones that you're probably most familiar with: glipizide, glyburide, Amaryl, etc. And I'm going to talk about them in detail in a second. Metformin or glucophage, been around in the United States since around 1995. It's been a huge workhorse, along with the sulfonylureas. Pioglitazone, also called Actos, which is the brand name. And then there's generic insulins, and we'll talk about those. So let's talk about sulfonylureas first. So basically, they are extremely inexpensive, and they're available around the world, and they cost pennies a pill. You'll never get those medications turned down by your insurance company. They work extremely well to lower your A1C. They're very effective. What can happen with these medications, and it's good to know, and it's not a reason not to take them, that you can get hypoglycemic if you're on too high a dose. If you miss a meal, if you over-exercise, that can happen. So that's just important to know. Also, it can cause a little bit of weight gain. These medications work by stimulating your pancreas to secrete a little more insulin. That leads to a little bit of weight gain. Some people don't gain any at all. And for those that do gain weight, it's not very much, probably less than 5 pounds, but everybody is different. And what about metformin? Metformin is also very inexpensive, used around the world extensively, been on the market, as I mentioned, for many years. So we know the safety profile, and it's probably, well, it is the drug of choice, the first drug of choice when you get type 2, recommended by most diabetes organizations. And it's also very effective at lowering your A1C. It does not cause hypoglycemia, meaning that if that's the only drug you're on, you can take it, you could take the highest dose, you could miss a meal, you could exercise a lot, you will not get hypoglycemic. So that's a nice safety issue as well. It does not cause any weight gain like the sulfonylurea group. And in a small number of people, it can lead to some GI issues. And the way we describe it in our medical textbooks is loose stools. Not so much terrible diarrhea, although that's possible. And usually when that happens, we use a lower dose, and we also use once a day metformin, which is softer on the stomach. So, but there are people out there, I've had patients through the years that just cannot tolerate any dose of metformin. And so this is something just to be knowledgeable about. And the dosage is typically 1,000 milligrams twice a day, but it takes, you should start off on a lower dose and build up slowly. And that's something that you and your doctor can talk about. Okay, pioglitazone, Actos, called insulin sensitizers. When these drugs were being developed, the whole diabetes community was super excited, because one of the main defects of type 2 diabetes is this medical phrase called insulin resistance. And this medication reduces insulin resistance. But as we started to use it, we realized it had some side effects. So it's probably the most effective oral medications in terms of lowering your A1C, and it does not cause hypoglycemia, and that's nice. You can take it along with metformin. That also does not cause hypoglycemia. No issues there, but there are some issues. You can get weight gain, more weight gain than you see with the sulfonylureas, and the weight gain is somewhat related to the dose you're on. I'll tell you in a second that the dose goes from 45 milligrams, 15 milligrams once a day, 30 to 45. And there's kind of a dose relationship. It can lead to fluid retention, which probably relates or explains some of the weight gain. And if you have ever had a cardiac condition called congestive heart failure, If you've had it, you know what it is. Then Actos is definitely contraindicated, and your doctor should not prescribe it for you. And so it does have a little bit of baggage. And once again, there's the dosing range, 15 to 45. What I try to do with my patients is to get them on the lowest effective dose of Actos. And I can tell you it's an extremely important medication in our whole toolbox, but it does have a little more baggage than some of the other medications. Now, these two classes of agents, the GLP-1 receptor agonists, I'll show you their names in a second, and the SGLT2 inhibitors, they're the latest classes that have been shown to not only lower glucose, but protect your heart and your kidneys and lead to weight loss. Now, why am I presenting them here? Because they're not generic and they're expensive if you had to pay out of pocket. Some insurance companies give people a little bit of grief for them, but I do believe that you need to look at the resource access page of our website to see if your insurance company or Medicare covers one for you. So this is a list of the SGLT2 inhibitors. You've all seen the ads on television, especially for Varziga and Jardiance. It's very important to know that these drugs do a lot of good things. They lower your A1C. They lead to weight loss. They lower your blood pressure, which is always a good thing. They do not cause hypoglycemia, and they protect your heart, especially congestive heart failure. And it's been shown also that they protect your kidneys. And there's 4 on the market, as I just showed you. They're all just a touch different, but they're a pretty homogeneous group of medications in that same class. Why do I have a picture of a kid peeing and a handful of sugar cubes? That's how this drug works. It helps push out the sugar in your blood into your urine. So this is a very important class, especially now that we know that it protects the heart and the kidney in addition to glucose. So, well, I'll show you in a few slides from now a great lecture in the Type 2 Video Vault that you can go to and get more information on the SGLT2 inhibitors and the GLP-1 receptor agonists. These are injectable. They're once weekly now. There's actually an oral form. And they do all the things that SGLT2s do, but they reduce heart attacks and strokes. They also lead to, I'd say, more significant weight loss, and they do not cause hypoglycemia. And these drugs can be taken together, and they are often taken together. And the other thing is, these medications, like the common ones are Victoza, Trulicity, Ozempic, they have higher doses. The companies have tested the higher doses that lead to greater weight loss and greater A1C reductions. And they actually have their own names and are indicated for, quote unquote, obesity as the primary indication to prescribe these drugs, even though they're the same exact medication, just in higher doses. And once again, we have a great lecture by Ginny Luna, who's an endocrinologist specializing in obesity. Now, lastly, before I get on to more generic options, are the fixed ratio combinations. There's Soliqua and Zoltify. Don't ask me where they get these names. Sanofi and Novo Nordisk make these. These are fixed ratios of a GLP-1 receptor agonist with all the benefits and a basal insulin. And the topic I'm going to speak about next is how to properly use basal insulins, which is a great choice for those of you on a budget. So just to let you know, they have these. There's lots of things on our resource and access website section of our website, how you can get these at a lower cost. So this is the lecture I was telling you about. It's called Making Type 2 Diabetes a Breeze, given by myself and an excellent endocrinologist, Tricia Santos. And it gets into these, I would say, more expensive, hard to get medications that have these very special benefits in much greater detail. And this lecture covers a lot of different issues as well. So that's right in our Type 2 section of our Video Vault. Okay, now What typically happens in clinic, my observations by primary care doctors and endocrinologists, that because people are not that excited about starting an injectable, they want to try all the oral medications first. And that's typically what happens. Now, if you go on all the oral medications that are appropriate to combine together, and you're tolerating them well, but your A1C is still elevated, then you go to a second option, which is starting 1 shot a day of a basal insulin. Now that goes on top of all the medications you're taking. I know you don't like to take a ton of meds, no one does, but in type 2 diabetes, we do not substitute diabetes medications, except for, I'd say not frequent situations. Now, the other option is to start a GLP-1 receptor agonist before basal insulin on top of all the oral medications. Now, the reason why we're going to talk about basal insulin is because you can do that on a budget, whereas you cannot do the GLP-1 agents on a budget. But if you can get those somehow reduced price, part of your plan, Medicare, that's typically used before basal insulin, unless your A1C is through the roof. If your A1C is above 9%, then everyone recommends go to insulin first. Doesn't mean you cannot add a GLP-1 later on. I told you this lecture is very sophisticated. You guys are smart, so I know you can handle it. And I know I speak quickly, but this is why it's recorded, so you can stop it and do a little rewind in case you want to hear it twice. Okay, let's talk about basal insulin. I can't tell you how effective 1 shot a day of basal insulin is in terms of lowering your A1C, allowing the oral medications you're already taking to work much better. Now, it's not just 1 shot a day of basal insulin. You can't just start it. You're going to have to titrate it to the maximum effective dose. And that's the dose that reduces your morning blood sugar to a desirable range. Now, this slide shows what we call the time course of action of the older insulins. And you can see that I circled NPH, which has kind of a peak. We call that an intermediate acting insulin, but it's still in the category of basal. And then there's insulin glargine, which is generic now. Once again, because it's an insulin, we call it a biosimilar. And there's actually 2 generic Lantuses, which is glargine. Every drug has a chemical name and a branding name. So glargine is Lantus. I have a little table here to show you, and you can see that down here are the 2 biosimilars called Basaglar and Semglee, made by 2 different companies. And the reason why they went through the hassles of getting these, of designing these medications to copy Lantus is because Lantus is a blockbuster. It's been around since 2000. And they want a piece of the action. I can tell you also that the FDA does its job extremely well in making sure that these biosimilars are safe and work extremely similar to Lantus, which is the original basal insulin. Yeah, and there we have the other intermediate acting insulin, NPH. And NPH is still used a lot these days. And if you're only eligible for NPH, then there is a very effective way you can use it as basal insulin plus your orals. Remember, most of the time basal insulin is not used alone. It's added on and underscore added. So here's just a picture of some of the insulins. There's Basaglar, there's Semglee at the bottom. And just to point out too that the Rely On brand insulin, which is just Novo Nordisk insulin, you can get it at Walmart for $24.88 a vial, which has 1,000 units in it. So it's a good way to get insulin cheap. Since the price of insulin has gone up in the last couple of years, there's a ton of insulin access sites available. Each insulin company has their own, and many other organizations want to make sure that insulin is available to everybody. There was an article that just came out in the last couple days that during the pandemic, 1.3 million Americans with diabetes on insulin were rationing their dose because they were afraid they were going to run out. So this is, you can't live without insulin. If you're a type 2 and stop your insulin, you're not going to go down the tubes like a person with type 1 like myself. You get sick within hours. You guys will just, blood sugar will go up, it'll go extremely high, you might start to feel badly, and then you'll eventually crump. That's a medical phrase. So this is how we use the intermediate and long-acting insulin as a basal component. Now, I showed you that time course of action of NPH. We call it an intermediate acting insulin. If you're using NPH as your basal insulin, remember this, you have to give it at bedtime. And if you're using Lantus or the biosimilar or any other basal insulin like Livamir, some of the newer ones, you may get your hands on those, Toujeo, Tresiba, then you could take it pretty much any time of the day, morning or night. But NPH, because it doesn't last as long, you want it peaking and lasting overnight to bring down your morning blood sugar. That's the key, to start off the day with a good blood sugar. Now, this is the titration sheet we use in clinic, and you can see how this is sort of an example how we fill it out. Start with your dose of basal insulin, whatever it is. This says once a day in the morning, so typically Lantus. Start with 20 units. And I like to recommend to patients I follow to titrate your dose every single day. You wake up in the morning, you check your blood sugar, and if it is above 140, as it says right there, you're going to increase your dose by 2 units. If it's below 90, you're going to subtract your dose by 2 units. If your morning blood sugar is between 90 and 140, no change. If you can't test your blood sugar in the morning, just use the dose you used before. If you're taking your long-acting insulin in the morning, it's quite easy. Check your blood sugar, see what the sheet says, go up, go down, or make no changes, then go on with your day. And if you take your basal insulin at night, you're going to have to write down your morning blood sugar so you remember what to do with your nighttime dose. This is it. Basically, you need to titrate your dose every single day. Now, once you get to the dose that your body needs, you'll hardly make any changes, and you can probably go more days without testing. So that's very, very important. A lot of people get started on 10 or 15 or 20 units, then the doctor never tells them to change their dose, or they say, come in 3 months with your blood sugars, and you're like 250 the whole time. Oh, let's go up on your dose. You need to sort of titrate your own dose. Now, I'm not your doctor, and so whatever you do, if you're going to titrate your own dose, print up this page or copy it down, run it by your healthcare professional, make sure you get their approval. Okay, now, the purpose of this slide is to tell you that even though you might get your morning blood sugar down to a desirable range, you're already on 1, 2, 3 oral medications. If your A1C is still not at your individualized goal, then you have to think about adding a mealtime insulin. We call that basal, we call that bolus or mealtime. So in this part of the graph, you can see that basal insulin was started, and if the A1C is not less than 7, then what you should do is start fast-acting insulin. I'll show you those different inexpensive ones on subsequent slides with your largest meal of the day. Now, a lot of people pick dinner, and that's important. And the point I want to make to you is, us type 1s, if we are on basal bolus therapy, you have to take basal with bolus or mealtime insulin with every meal and snack. That's not true for type 2. Remember, your pancreas probably works to some degree. You may only need a little bit of help controlling 1 meal a day. So you do that. You start it with, let's say you start it with dinner. You check your bedtime blood sugar or 2 hours after eating, and you want to make sure that your post-meal blood sugar is in a desirable range. Let's say less than 180, less than 200 even. And if it is, that's good. And then you wait to see what your A1C is after 3 months. But if it's still elevated, guess what? Then you have to consider going to a second meal. And then if your A1C is still elevated after 3 months on a second meal, then you might need what we call a full multiple daily injection regimen. Some of you type 2s need that. Typically, if you've had type 2 a long time. So remember, when you have type 2 diabetes, you're going to start off on oral medications most likely, and you might do awesome for many years. Then you may need to add a basal insulin. Then you may do well once you titrate that morning blood sugar for a long time. And then you may need to add fast-acting insulin. This is what we call the natural progression of type 2 diabetes. So remember, don't get discouraged if you have to add more medication on. This is all part of the natural history. Okay, what I just showed you was a basal bolus approach. This is sort of what it looks like. You can see that shaded gray area is the fast-acting insulin given at every meal, and then the basal insulin giving you a baseline of insulin all night long. And what those two and the solid lines are typically what you would look like if you matched it with the individual's own pancreatic insulin secretion. Okay, so what are the fast-acting insulins that are inexpensive? Well, there's regular insulin. Lilly makes it, Novo Nordisk makes it. And then there are what we call fast-acting analogs, and there is a biosimilar or generic form now. And the rapid-acting analogs are a little bit better. They work faster, and they work a little more aggressively, and they get out of your system quicker. So if you look at this graph, there's a medication called Admelog, which is a generic to Novolog, which is a rapid-acting insulin. And once again, these insulins have been around a long time, and you have to just look around and see which ones you're eligible for. And so there's the older regular insulin that is the least expensive that you can get at Walmart and other distributors. Now, I thought I would just show you inhaled insulin. There's a whole lecture of it on our website. This is not generic, and typically it's quite expensive if you pay cash. But once again, depending on your insurance, you may be eligible to get a discount. This is the size of the inhaler. You can see that you put the little cartridges of insulin inside it, and you take a little inhalation, and there's different doses, and this negates the need for an injection. And Afrezza is what we call a rapid on, rapid off insulin. And you can see it there compared to the injectable insulin that doesn't peak as high and hangs around a lot longer. So that's all I'm going to tell you, just because I feel like you should know about it. Okay, what about monitoring your diabetes? For those of you that have to prick your finger and use a glucose meter, more power to you. These meters are so important that they tell you what your blood sugar is at critical times to help you prevent lows and to help you adjust your insulin dose. And the one thing that bugs me on these slides is that I should show you that they're always advertised with normal numbers. And I dare a company to come out with a meter with these type of numbers. And then there's like a little phrase pops up on the screen, it says son of a, and then even a little bit of music that may come out if you're above 200. Here it is. Remember that song? All right, let's go on. You know what? These jokes are so much better when there's an audience of 1,000 people, but just bear with me. Now, there's the Rely On insulin. There's a Rely On glucose meter. I mean, it's $10 glucose meter. 50 strips for $14. That's a great deal. And you don't need to test a zillion times a day. It really depends what regimen you're on. If you're on basal insulin at night, one of the most important times to test is in the morning. And then if you get your morning down and your A1C is still high, you may start to test at other times to figure out which meal is causing you to jump up the most. Now, if you're on the other end of the spectrum, that if you're on fast acting with every meal and basal, you might need to test more frequently, up to 4 or 5 times a day to get a handle on your insulin dose. So remember, don't just think you got to prick your finger a zillion times a day. You want to pick your number of times and the time of the day that's going to help you make the best adjustments with your insulin. Okay, now what about your A1C? If you don't have access to an A1C test in the lab, or you get charged a ton of money every time you go to the lab, you can get a test that's extremely accurate at the pharmacy. It basically costs about $8 to $12 a test. You don't have to test very often. You know, every 3 months at the most. If you're under good control, every 6 months, and you can do it in the comfort of your own home. And if you can prick your finger for a glucose test, then you can follow the instructions for the A1C kit at home. Okay, now I'm going to mention continuous glucose monitoring, even though many of you, even with good insurance, are not eligible if you're not on 3 or more injections of insulin a day. But it is probably one of the most important tools that you can get. These are devices that you put in the sensor under the skin. It gives you a glucose every 5 minutes, alerts and alarms to tell you when you're getting too high or too low. And there's different brands out there. Dexcom has the G6, soon to have the G7. The Libre 2 has the now Libre 3. They're all a little bit different, but they all give you a blood sugar very frequently with these trend arrows as well. I'm not going to get into the details of the CGM, but because we have a great lecture on that on our website. This is an implantable continuous glucose monitor called the Eversense E3. You put it under the skin, not you, but your caregiver. It's about a 15-minute office procedure. It stays under the skin for 180 days, and you wear a transmitter on the outside of your skin, and the blood sugar every 5 minutes goes to your smartphone or your smartwatch. So it's different form factors. You got to find the one that works the best for you. Okay. Now, once you get a CGM, there's a kind of a new metric called time and range. You may have heard about it. Time and range is the percent of time your blood sugar is between what all the experts say is the ideal time between before and after eating, 70 and 180. If you're at 70% time and range, then you're doing extremely well, as long as you're not having too many lows or time below range. So once again, I'm not going to get into the metrics of a CGM report, but this is something that you should learn about. And if you can get a CGM, I don't care what type of type 2 diabetes you have, I don't care if you're pre-diabetic, having a CGM will help you understand what's going on with your diabetes. Okay, there's the ideal range. Okay, this is just an example how it really helps tailor therapy. This is a patient of mine. He's type 2. He's on oral medications, and he's on basal. But look what happens right there at dinner time. He pops up, and that's what's causing his A1C to be elevated. So it was a quick fix. We gave him 1 shot of fast-acting insulin at dinner time. We titrated the dose based on his bedtime blood sugar, and that brought his A1C down to about 7%. So it's just an example how effective it could be. And remember, these downloads, this information is available to you, the individual using them. Okay, now to finish up my talk with some fun but educational pictures. If you're on insulin or a sulfonylurea, you can get low. If you eat all the stuff on the left, ice cream, cupcakes, peanut butter, fig Newtons, that's not the best way to treat a low, because your blood sugar won't rise very quickly. You'll consume a couple thousand calories, and your blood sugar eventually will rebound through the roof. You want fast-acting carbs, glucose tabs, juice, candy corns, my favorite, because these kind of candies are pure sugar. And they will raise your blood sugar quickly. And you should always limit the amount you take, typically 15 grams. Now, I should mention the emergency glucagon kit. If you get so low you can't swallow and someone else has to help you, this is the old kit. It's cumbersome. It's hard. The instructions are difficult, but it's kind of the generic form of an emergency glucagon kit. And if you get one, if you're on insulin, you should have one. Teach your loved ones how to use it. The pharmacy person will tell you how to use it as well. It's not hard, but it's only hard if you've never used it until your loved one is having a seizure from low blood sugar and you're freaking out. Now, here are the 2 new forms of treating serious low. These are both glucagon preparations. One is made by Lilly called Baqsimi. The other is made by Xeris called Gvoke. They're very easy to give. One's a nasal spray. The other is kind of like an EpiPen. You pull off the tip, you push it against the skin, auto injects it. No mixing, and it's so much easier. And if you're on insulin, you should definitely try to get one of these. If not, get one of the older kits and learn how to use it. Now, what about exercise? Okay, one of my patients said this, and I thought it was just so smart. Exercise makes up for mistakes. Exercise is so important, and everyone has to find their own level. There's some great videos in our video vault on exercise by 2 or 3 specialists. Does anybody see anything usual about this picture? Yep, that's right. No one takes the stairs anymore. Everyone jumps on that escalator. Every bit of exercise you do during your normal daily activities, believe me, adds up during the day. Most smartphones will have a little app counting your steps, up flights of stairs. You know, get into a little competition with yourself. Now, what about carbohydrates? What I wanted to do is jump to this next slide, which is a list of low-carb foods. That's powdered peanut butter, 1/3 the calories of regular peanut butter. Then you can see I have beef jerky, I got cauliflower rice, I got crackers made solely of cheese, I got nuts, and one of my favorite things to cook with is egg beaters. Not only super low in calories, but filling and low in cholesterol levels. And so if you want to get your diabetes under better control, you're tired of gaining weight, get on a fairly low carbohydrate diet, not Atkins where you're driving yourself crazy and undoable over the long term, but just start making substitutions. Cauliflower rice is awesome, and I think it just depends on what you mix it with to give it a better flavor. Now, here are some of my recipes on our website. This is my maple chicken sausage scramble made out of the sausages that I get at the store, but they're lower in calories because they're chicken. They're flavored with maple flavoring, really good. And egg beaters. Here is my famous Taco Tuesday. It doesn't have to be Tuesday. It's basically a taco except no carbohydrates in the shell because it's lettuce. And you can use turkey meat, you can use chicken, you could use beef, you could use tofu if you want. And I like the concept of holding a taco in the crispy lettuce. Okay, this is Edelman's Big Ass Salad. And this is basically, I buy a whole bunch of stuff at the store, I chop it up, put it in a huge bowl so I can have it for 2 or 3 meals. And then the key is the salad dressing. I say if you're gonna eat a salad, might as well get good salad dressing. This dressing I'm holding is incredible. It's called Kiwi's. It's a smoked sesame dressing. It's incredible. Now, this is my famous beta cell islet omelet. There's 3 fried eggs over a thin layer of hash browns, bacon and avocado around the outside, and there's a rim of ketchup there. That's my own invention. And I'm a guy, I can cook. This is a famous soup I have with cauliflower and broccoli, and you can read all these recipes online. This is my famous matzo ball soup. I call it elephant ball soup because I make the balls really big, and there's carbs in those matzo balls. And this is my Mick Edelman. This is a great invention. You get these little cupcake cups, you put egg beaters in there, put it in the microwave. Once you cook it for, I can't remember, 2 to 3 minutes, you put it inside an English muffin, which is only about 25 grams of carbs, half of a bagel. And you have a really nice breakfast. You can eat it anytime you want. Just remember, the foods we eat have a ton of sugar in it. I used to think cinnamon was the cure for type 2, and eating 2, 3 Cinnabons a day just didn't do it for me. Okay, this last part I'm going to just end with. On the website, there's tons of resources. We have assistance programs, Medicare assistance programs, pharmaceutical assistance programs, additional resources from all the different companies, even Costco. So there's just, at this time, too many to count. I think one of the silver linings of COVID is that these programs came out. This is if you go to our tcoid.org/access, you will get this on your computer screen. Then you'll go from there and you can see all the different buttons on the different areas depending on what you need, depending if you're on Medicare. Look at all the links we've organized for you that you can go and get information. We probably spent 3 or 4 months putting this section of our website together. Please take a look. Even if you're not on an extreme budget, you're able to save money. Why not? Then you can donate it to TCOID. Just a suggestion. This is a picture of our virtual health fair when you go to one of our conferences. So that's important. And in our video vault that I've mentioned several times, there's a type 1 section and a type 2 section. Please go in there because there's some awesome lectures by lots of very smart but healthcare professionals that know how to present. And we got our own songs. We have game shows, but every single one thing we do, even though it's entertaining, we try to make it educational as well. This is also our dose of Dr. E&P. On this particular one, we're talking about the trend arrows, how to respond to them if you're wearing a CGM, and if you can type in any topic under topics A to Z, and you can go right to that area. You know, we have other areas on our website that are just packed full with information. And we also have a podcast, as you can see from this screen. And no matter what your way of learning, whether it's auditory, visual, or both, we got lots of things for you. And lastly, we have Facebook groups for people with type 1, type 2, and type 3 diabetes. So remember, it's never too late to take control of your diabetes, even on the cheap. Thank you.